Welcome to the Dental Capsule. In this series, we'll cover different dental topics and real clinical situations in short, easy-to-follow capsules, designed to help us improve how we manage our daily cases.
In this capsule, we're going to talk about how to manage patients who are receiving or have completed radiotherapy to the oral and maxillofacial region. Radiotherapy can save a patient's life, but when the radiation field includes the jaws and oral tissues, the rules of dentistry change completely. First, what does radiotherapy actually do? It damages the DNA of tumor cells, but it also affects the salivary glands, the oral mucosa, the muscles, and, most importantly, the blood supply of the bone. So these patients often develop mucositis, severe dry mouth, radiation-induced caries, which usually hits the cervical and incisal thirds in a rapid pattern, trismus and soft tissue fibrosis, periodontal breakdown, and reduced vascularity of the jawbone. And that brings us to the most feared complication, osteoradionecrosis. Osteoradionecrosis happens when a radiated bone loses its ability to heal. The bone becomes exposed, infected, and slowly breaks down. Sometimes after trauma, sometimes after an extraction, and sometimes with no obvious trigger at all. It is painful, difficult to treat, and completely preventable if we manage these patients correctly. Before radiotherapy, the most important phase. This is where you can prevent almost every long-term complication. Here's what you should do. Complete a thorough oral exam and radiographs. Remove all sources of infection. Extract hopeless or questionable teeth at least 14 to 21 days before radiotherapy. Do scaling and polishing. Start a daily fluoride regimen and provide custom fluoride trays. Teach the patient about expected dry mouth, jaw-stretching exercises, and strict oral hygiene. And what should you avoid? Don't leave questionable teeth in the radiation field. And don't postpone necessary extractions until during or after radiotherapy. During radiotherapy, your priorities now are comfort, protection, and maintaining oral hygiene. You can manage mucositis with saline rinses, benzidamine, and pain control. Treat candidiasis early. Encourage hydration. Continue daily fluoride. Support gentle brushing. Monitor trismus and start early jaw exercises. But avoid any invasive procedure. The bone is hypoxic, healing is delayed, and the risk of osteoradionecrosis is extremely high. So during radiotherapy, no extractions, no implants, no periodontal or surgical procedures. After radiotherapy, and this lasts for life, these patients continue to face chronic dry mouth, high caries risk, fibrosis and trismus, and lifelong susceptibility to osteoradionecrosis, especially in the mandible. So your long-term management should include daily high fluoride use, recall appointments every 3 months, aggressive caries control, ongoing oral hygiene support, jaw physiotherapy, avoiding trauma and surgeries to irradiated bone. Carious teeth should be treated by restoration or root canal treatment. If the tooth is non-restorable, do root canal treatment and coronectomy to a subgingival level to keep the root embedded within the bone. And if an extraction becomes absolutely unavoidable, use the most atraumatic approach possible. Consider antibiotics and refer for hyperbaric oxygen depending on guidelines and the oncologist's recommendation. Remember, many recent papers show that the risk of osteoradionecrosis does not decrease with time. It actually increases after 6 to 12 months due to progressive fibrosis. Your goal as the dentist: protect the irradiated tissues, preserve teeth whenever possible, and, above everything else, prevent osteoradionecrosis.
Thanks for watching. If you found this helpful, don't forget to like and subscribe. Share your thoughts or questions in the comments. We'd love to discuss them with you. See you in the next capsule.